Welcome. Thanks for attending today. So we are pre-recording this video. I'm visiting Matt in San Diego. We're doing some dissection and we're doing some techniques and putting them on video for some future classes that we're working on. So this will be pre-recorded and hopefully it'll be an enjoyable experience for everybody.
Good morning, everybody. So Brian and I are presenting today a brief clinical discussion on foot over pronation and the spleen and kidney channels. This topic is in depth, and a 30-minute webinar is highlighting only a portion of the content. However, we felt that the information in this presentation is providing the viewer some ideas that can be integrated into your own clinical practice. And we're going to start this presentation with three primary biomechanical components in foot pronation that also leads to foot over pronation. So Brian, do you want to talk about the video?
Yeah, sure. So put this video together and it uses a flexible foot model. You'll see the video in just a moment. Just a little bit of information on the video. When I'm demonstrating, I'm pushing this foot down on a hard surface so that it takes the foot into pronation so that we can look at the components of pronation. But I really flatten that foot down to the surface to highlight those particular movements. In real life, and there's a disclaimer that says this, in real life, this would really be more like foot over pronation. But it helps visualize those particular movements, and that's why it's really flattened, and you'll see what I'm talking about in just a second.
Yeah, so just so that you know that it's not going to be on your end, this video, the first 5 seconds, there pauses just a little bit. After that, it runs really quite smooth. So here we go.
Normal foot pronation occurs
and it's the longest pause that we've had.
during walking and running. During the impact and weight-bearing phase of gait, the foot falls into pronation. This movement helps absorb shock and builds elastic tension in structures such as the plantar fascia, which, much like a trampoline, will create an elastic recoil during the next phase of gait. Normal pronation involves a combination of foot abduction, a motion in the transverse plane, eversion at the subtalar joint, a motion in the frontal plane, and ankle dorsiflexion, a movement in the sagittal plane. During ankle dorsiflexion, there is also a medial rotation of the tibia. During these movements, the spleen and kidney channel sinews become lengthened. They also help control the motion and prevent the foot from overpronating, so proper tone in these channel sinews is necessary for support.
All right, so the video, it's very biomechanical. It's an important thing to understand when you're a sports acupuncturist and you're working with athletes, or you're working really with anybody who has injuries that have a component of foot over pronation that's influencing the condition. But so I would argue just understanding the biomechanics is important, but even from a channel perspective, understanding the different components of the biomechanics is important because it tells us a little something about the channel sinews, and it tells us a little something about the position of those channels and the influence and relationship of one channel to the next. So this slide is going over a little bit of that and talking about an overpronated foot. Really what you saw in the video is much of a collapse as we saw on that foot arch. And with that overpronation, number of things happen that cause really a downward collapse in the yin channels. We saw that in the video with the spleen and kidney channel in particular, where those channels are kind of collapsed and dropped down, and an excessive upward pulling from the yang related channels like the urinary bladder channel in particular. So we see this in the image. The chi collapses downward on the inside and the chi is pulled upwards on the yang side. This can lead to a number of injuries of the foot, in particular plantar fasciitis or plantar fasciosis. It can influence things like shin splints because of the collapse and the excessive pulling of the muscles that attach onto the tibia. It can be a component of medial knee pain because of the internal rotation that occurs in the tibia. And really that can transfer all the way up into the hip and back and neck and upwards. I mean, it really has a global influence on the body when the foot over collapses like that. So we have another image here that's showing this in a little bit more detail. On the yin side in yellow, we have the spleen and stomach chi collapsing downward. Both of those, the yellow on the inside of the tibia, referencing the tib posterior, is a really major influence of a particular muscle that holds up the arch, that if that muscle is weak, if the spleen chi is weak in particular, there's going to be a tendency for that muscle to be weak and not lift and hold up the arch in the proper way. Tib anterior on the stomach side is also a big part of that because it crosses over and attaches to the medial arch. Both of those really help lift the medial arch. And then you have the upward pulling from the urinary bladder, channel sinew, especially through the Peroneus, Longus, and Brevis, which we'll look at. Right, next slide. And this is looking at it from the back. So if you look at the right side of the foot image, you can see that the calcaneus tilts. This is part of the eversion that we saw in the video. The calcaneus tilts medial. The top of it kind of falls medial. And you can see a bowing of the Achilles tendon. So we can see a dropping of the kidney sinew channel and a lifting of the urinary bladder. In particular, the soleus, part of the kidney sinew channel, has more fibers that attach to the medial part of the calcaneus, whereas the gastrocnemius, the more superficial muscle, we can see that on the left where it's kind of splayed back and kind of off to the side. The gastrocnemius attaches on the lateral side. They both form the Achilles tendon, but if you tease those fibers away, the gastroc would attach to the lateral portion, soleus on the medial portion. The medial portion is going to be dropped and pulled excessively long in relationship to the lateral portion. So another influence of the channel sinews. All right, next slide. Oh, sorry. Go ahead, Matt.
Yeah, so I think the next one's going to be the navicular drop. Yes. So let's go back. The image on the right, you can see as Brian was discussing the imbalances of these sinew channels. This particular view posterior is called Helbing sign that we're going to be discussing here in just a second. There's another way of actually looking at this as well. Because the tibialis posterior spleen sinew channel attaches to the navicular bone, using the navicular drop test is really quite efficient in looking at the lengthening of that tendon in the spleen channel. So when the person is in a non-weight bearing position, which is the top image, you can measure to see how high the navicular bone is. That blue dot is at kidney 2, which we know kidney 2 is located just underneath the inferior border of the navicular bone. The bottom image is going to be a full weight bearing position. So you can see that blue dot has dropped significantly, indicating that the navicular bone is being dropped, as well as the tibialis posterior tendon, spleen sinew channel becoming lengthened. The medial arch is collapsing. So here we've got Helbing sign, the calcaneal eversion. So the calcaneus is tilting into an everted position. You've got a bowing of the Achilles tendon, as we discussed before. This can lead to a number of different injuries, tarsal tunnel syndrome, Achilles tendinopathy, etc. So looking at this Helbing sign is an indication for foot over pronation. Now, there's a lot of people in the population that are walking around like this and they don't have any pain whatsoever. But with overuse, eventually pain will come just because it's such a mechanical problem, in addition to the spleen and kidney channels being lengthened. And as we'll discuss in just a little while or momentarily, the effect that the actual organs have play into this as well. So with this particular one, you can see this test, foot abduction, or it's also a foot flare sign. You can look at this from an anterior view, or you can look at it from a posterior view. In the anterior view, you can see how that kidney sinew channel is long and it's dropped, going from kidney 4, kidney 5, kidney 6. You can see how kidney 2 has dropped. It's a foot flare sign. So that foot's going into abduction, lengthening that kidney sinew. So the tissues involved in the kidney sinew are lengthened and they don't have very much integrity here at all. They're not supporting the arch. Whereas on the other side, the Biao-Li, or the internal-external relationship to the kidney, being the urinary bladder sinew channel, is in a shortened position. So we're going to talk a bit more about how to be able to treat that. Brian, is there anything that you want to say to that before we go to the next slide?
Yeah, you know, the lines that are representing the medial and lateral side, of course, the kidney and UB, it's the channel, but it's also the channel sinews, which on the inside of the foot is the abductor illusus. So it really does kind of go along the medial side to the big toe like that. And for that matter, the primary channel is also over lengthened like that. But in particular, this is showing the channel sinews. And then the abductor digiti minimi for the urinary bladder channel, which attaches to the minimi, the little toe. So it's also, follows that UB channel.
So in a moment, we'll show you some needle techniques and myofascial work for these two muscles in particular. All right, so then the intrinsic foot muscles are out of balance. So the abductor hallucis, as Brian just discussed on the kidney channel, is locked long and it fails to support the medial arch, and the abductor digiti minimi is going to be locked short. Brian, do you want to take it away and we'll comment on both of these slides?
Yeah, so this, again, very biomechanical. That in and of itself is going to increase people's ability to work with flat foot, with pes planus and foot over pronation, and many injuries that might come from that. But bringing it back into a holistic view that's in Chinese medicine, we can start to look at some relationships of something called acquired flat foot, something that develops later in life, usually in the 40 plus age group, especially more common with women. There's usually relationships. This is a very Western discussion, but we're going to bring it back into the Chinese medicine discussion here in a second. But this usually is involved with a number of types of illnesses such as hypertension, diabetes, obesity. So there's a correlation with those types of illnesses and acquired flat foot, where people start having a loss of integrity in the tib posterior muscle and a collapse of the foot.
Yeah. So the unusual or prolonged stress, that's going to tax spleen qi and kidney qi. Faulty biomechanics, ligament laxity in particular, that's going to be kidney qi as well. And the normal aging process. And as we know, kidney qi is on the decline the older that we get. So let's move on to the next slide. Go ahead, B.
Just some information from research. Actually, Matt, why don't you take this one?
Yeah, so posterior tibial tendon dysfunction is the most common cause of adult acquired foot. So basically, we're just kind of backing this up with acquired flat foot deformity. Beals states that posterior tibial tendon insufficiency, remember that's what attaches to the navicular bone that drops, is the most common cause of acquired adult flat foot deformity. The exact etiology of this disorder is still unknown, but for a TCM practitioner, I think it really gives a lot of credit to looking at kidney qi and spleen qi when you're treating somebody with pes planus, because they're coming in with an injury. So what we did is we looked at two different references, the Clinical Handbook of Internal Medicine by McLean, and also the Treatment of Modern Western Medical Diseases with Chinese Medicine by Flaws and Philip Sunal. We just jotted these down here. You can see in the bulleted points. Hypertension, yes, liver yang rising. You've got phlegm fire. Well, the spleen and the kidney is going to be associated with phlegm. Liver and kidney yin deficiency, absolutely, you'll see that also with hypertension. So when somebody has hypertension and flat feet, we're looking at the kidney channel there. There's also the pattern of Chong and Ren dysregulation, which is interesting because you see the master points of Chong being spleen 4 and then Ren being, being lung 7, kidney 6. Blood stasis is something else with hypertension. And then obesity, what these authors are talking about, stomach heat with food stagnation. Well, stomach heat, stomach being tibialis anterior, which can be in a lengthened position in pes planus. Phlegm dampness, you've got your spleen. There you've got spleen deficiency being qi deficiency as well as yang deficiency, allowing that collapse of the medial arch. So the strength of the organ itself being reflected within that channel, primary channel, and jin, not giving enough qi to be able to support that medial arch. And obesity, you've got liver and kidney yin deficiency as well as qi and blood stasis. Then diabetes, there's your stomach heat, so stomach channels being affected. Diabetes, spleen and stomach qi deficiency, there's your tibialis posterior spleen, tibialis anterior, not getting enough qi within the channel because of the organs. Overall qi and blood deficiency, phlegm again being spleen, Liver and spleen disharmony with heat. There's your spleen channel again. Kidney, heart, and liver yin deficiency. There's your kidney channel. Kidney and heart yang deficiency, kidney channel again, and kidney yin vacuity. So there's a lot of support with the spleen and the kidney channels here. Brian brought up a really good point about this. If we were able to do some kind of research with it. Brian, do you want to describe your idea that you and I were talking about yesterday?
Yeah, so in the acquired flat foot discussion from Western circles, they just basically say that there's correlation with hypertension, there's correlation with obesity and diabetes. What would be very curious, and I think it'd be great to study. It would take some time and resources, of course. Let's say you took hypertension and you took all the people with hypertension who had acquired flat foot. It'd be curious to see how many of those people had, if you differentiated them into patterns from a Chinese medicine standpoint, how many of those people had really more correlation with the spleen and kidney patterns, based on the fact that those are going to have a change in those related channels. And that my hypothesis, my guess would be that if you found the people with hypertension who have acquired flat foot, you'd have more phlegm fire, more liver and kidney yin deficiency, maybe not so much liver yang rising. Who knows? I'd be curious to find it, but that would be my guess.
Yeah, so the takeaway from this, everybody, is that, and this is something that we teach a lot in our education, in our school, is that when you're looking at musculoskeletal, it's never just musculoskeletal. There's always some kind of Zong Fu component, and we are TCM practitioners, so always look at that Zong Fu component and be able to supplement the musculoskeletal treatment. It should be held together. So this is something that a sheet for you guys to be able to take a look at. This is going to be just for the local muscles themselves that you can be able to treat, in addition to the person's constitutional points and Zong Fu. So the Peroneus longus and the Peroneus brevis, these are going to be locked short. They're going to be accessed. These muscles are going to be real primary in treating this. So you want to reduce the excess so that the deficiency starts to come up. So we'll address the deficiency as well. But since we don't have a heck of a lot of time on this webinar, we are going to be showing you the Peroneus longus and the Peroneus brevis needle technique. We're also going to be showing you the abductor hallucis and flexor hallucis brevis needle technique as well. There's also an image, I believe, of the abductor digiti minimi that you can be able to use. Mm-hmm. So, Brian, anything you want to say before we just move
Yeah, I'm sure there's people watching this who are going, Peroneus longus and brevis, that's on the gallbladder channel. This is interpretation, but go back and open up Deadman or any book that has image of the channel sinews. Of course, they just show topography. They're not showing in particular muscles, but you'll see that the urinary bladder sinew channel has a lateral branch that could be interpreted. We interpret it as Peroneus longus and brevis. Those muscles have a much stronger fascial connection to the hamstrings and link with the urinary bladder channel, whereas we put the gallbladder sinew channel more with the extensor digitorum longus, which is just in front of the fibula. And really, if you look at it from primary channels, you'd see the gallbladder 34 and many of the gallbladder points along the lower part of the channel would actually go right into extensor digitorum longus. So yeah, go back and check out those images and you'll see there's a lateral branch, and that's what we're interpreting as Peroneus longus and brevis.
In addition, Brian and I we proved this relationship on a cadaver specimen, and it's on our YouTube video channel, Sports Medicine Acupuncture, mm-hmm. where we put a needle into the Peroneus longus motor point, we put a needle into gallbladder 34, and then we put a needle into the biceps femoris, the hamstring motor point. We pulled on the biceps femoris motor point, and you could see where the force tension was going, and it was moving the Peroneus longus needle substantially, but not gallbladder 34. Mm-hmm. So this is really linking the urinary bladder sinew channel. That's on the YouTube channel, Sports Medicine Acupuncture, if you guys want to check that out. Let's go into the video showing the Peroneus longus and the Peroneus brevis. I'm going to set this up a little bit so you can see. Is that we have one needle in the Peroneus longus motor point, which is located just 2 cm below the head of the fibula. And then we have a needle in the Peroneus brevis that's angled upward. So we're twist the needle, we wrap the fibers around the brevis, and we're pulling down so that you'll see the needle moving on the Peroneus longus, because we want that chi to be moving downward. in pes planus with every step. As we talked about earlier in this webinar, the chi is moving upward on that lateral side, being the yang side. We want to pull it down. So here we go. Peroneus longus motor point, too soon down from the head of the fibula. Peroneus brevis motor point, one soon above gallbladder 35. This needle technique for the peroneals that are in a shortened position from foot over pronation. We want to try to be able to pull the muscle fibers downward in order to be able to change the chi within the channel, change the proprioception. When I wrap the fibers around the Peroneus brevis and I start to pull down, you can see the movement in the Peroneus longus motor point. So I'm going to maintain the traction. And you can see how that needle is moving. So therefore the muscles, the fascia, all the proprioception here is starting to change. And I'll hold this so the muscle can get used to being its new position. All right, so that needle technique is in combination with something that we talked about earlier, lifting up the medial arch. Mm-hmm. So this is a needle technique that you can't apply to everyone, but it is very useful to apply to those people that can handle the strong chi sensation. Using a thinner needle is also useful, but in my experience, you need to have this as a Chinese needle. Some of the needles that are coated will not allow the fibers to wrap around that needle. So it's a good idea to be able to have a Chinese needle. Watos are my favorite to use in this particular case, but again, you can use a thinner gauge needle. So the two muscles are the abductor hallucis and the flexor hallucis brevis that we're needling here. The motor points of each muscle found on the kidney and the spleen sinew channels are needled to lift the collapsed tissue and increase proprioception. So you're needling there underneath kidney 2, and then also you're needling halfway between spleen 3 and spleen 4, going into the muscles themselves, twisting the needle to patient tolerance, and then gently just lifting that arch up, so that you are starting to change the proprioception with that. Then you would leave those needles in place in addition to all the rest of the needles that we have in that formula, treating adjacent points, distal points, and also constitutional and zongfu.
Yeah, I might add something to that.
Sure.
As Matt mentioned, you're leaving those needles in place. So usually if they're in for 10 minutes and you go to bring the needle out, no problem, it comes out, the tissue is relaxed. You know, it might be the case that the needle wouldn't come out right away. That's the point, is you're trying to lift that tissue. But it usually will come out no problem. But do pay attention to which direction you turn the needle in case, it really doesn't happen with me this way, but in case it were to get stuck, you'd want to unwind it in the other direction. So if you're going clockwise, you know, make a note of that. And if the person can't tolerate this type of treatment, it's not too bad. You're going slow and gentle and into patient tolerance, but needling the motor points would still be useful on their own, but it's going to give a little bit more bang for the buck by doing this lifting technique.
Yeah, true. All right, so here's a needle technique that's kind of based on the same idea. Brian, do you want to go ahead and discuss that?
Yeah, the image, I'm just kind of glancing at this now and noticing that the little black line for UV63 and UV64 is just a pointer. The needles are copper kind of colored, so take note, or you can see my thumbs holding on to those needles. So same idea, the needles are put into UV64 and UV63. 64 is the motor point for the abductor digiti minimi, which has a strong connection to the lateral band of the plantar fascia. So UV62 would be into that lateral plantar fascial band. And then the needles are twisted gently and until they catch the tissue, until they catch the fascia, and then pulled away from each other to help widen that lateral portion of the urinary bladder sinew channel, the part that gets shortened as the foot goes into abduction. And that whole side of that lateral plantar fascia becomes shortened. You're widening that lateral band of the plantar fascia.
Yeah,
so
good.
reducing technique.
Yeah. So this technique, followed by a really good myofascial technique that we're going to show you an image here in just a second, is really quite good doing this technique and then the myofascial. So Brian, you want to take away some of the myofascial work?
Yeah, so myofascial work is really going to be following the same principles. So this, you can see the two knuckles on the on the Pronated, Longus, and Brevis going down that lateral band of the urinary bladder sinew channel. It's kind of widening that lateral band, but each time you're tractioning the tissue down and then widening, kind of like making little chevron type positions, and move down a little bit, bring the tissue down, widen, go down, next step. So the whole time you are widening that portion of the lateral compartment, which is containing the Peroneus, Longus, and Brevis, but you're bringing that tissue down. That's the key takeaway from this, is you're helping encourage the fascia and muscle and all the proprioceptors downward in the same way you were with the needle technique.
Yeah, starting from top, ending at the bottom.
Yeah,
good.
That lateral band would be pulling the foot into eversion, so you're helping correct that by dropping it.
Mm-hmm. Very useful after the needle technique. Let's see what the next myofascial release. Oh, it's an exercise. All right. So inchworm exercise. This is a very useful exercise for helping to restore some of the integrity in that medial arch. Inchworm, you can actually Google that if you wanted to, and you can get this step by step. You can see with the foot on the left, this is, I think, Brian's foot, so he doesn't have a pes planus on there, but if it was a flat foot, you can see as what he's doing in the middle image is he's bringing the first metatarsals and the big toe up toward the calcaneus as the calcaneus stays in place. So he's increasing the integrity of that medial arch. Then he puts his weight on the forefoot and he brings the calcaneus back, which will flatten the foot again. And then he repeats the exercise. This is an exercise that you could probably find step by step, I would think, on Google. This is also something that we teach in its entirety.
Yeah, I think, though, usually on Google, it's not going to be under inchworm. It's and because usually people don't walk it back like this, and it'd be called a short foot exercise.
But we modified that. Okay.
Yeah.
So the short foot exercise is going to be a little simpler than this one. So.
And that would be probably, you can find videos of that.
Curls, Brian, you want to take it away on this one?
Yeah, this one is, if you look at the kind of ghost image on the top little corner portion, that is you are taking the foot and you're dropping the medial arch. You're taking the foot into abduction and just, basically collapsing your weight into the medial arch. And then you're starting from a position, I guess, of dysfunction, and then you're curling the foot and lifting the medial arch. So this one would also strengthen those intrinsic muscles of the foot along the kidney and spleen channel, but it would also be calling on things like the tib posterior, because it starts to take the foot into a position that engages the tib posterior. So this is training both the intrinsic and extrinsic foot muscles.
Yeah, good. Yeah.
So the ghost image is the before, the full image is the after.
And it's not a ghost image because his foot's so white. It's actually because of the fade, right?
It's a little of that too.
Let's move on. Okay, there's the references. Right. So you guys, thank you very much for attending this. We want to thank the American Acupuncture Council for having us. This has been really a lot of fun. We hope that with this very complicated and in-depth topic, we just took some portions of it actually, and hopefully we gave you some useful insights or clinical pearls that you could be able to use to be able to help other people, to help your patients. Brian, thanks very much. It's always nice hanging out with you.
Yeah, and Matt, I do want to highlight that there is also on the YouTube channel, Sports Medicine Acupuncture, full needle treatment that shows both before and after for changes in the foot that was done in one of our classes.
Oh, that's true.
That covers this whole protocol basically, without the myofascial and corrective exercises, but just the needle portion.
Yeah, good point. Okay, well, thanks very much. Appreciate it.
Yeah, thank you.
All right, take care, everybody.